Now we're going to do the hip passive mobilizations. The first one is the passive mobilization of the hip inflection. We tell the patient to put in supine with the legs extended, and the therapist on the same side places the arm in the cup grip to support the leg during the passive hip mobilization, and one hand on the medial side of the knee and the other hand on the lateral side of the knee, and like that we will perform the mobilization. The next one is a variant of the first one, a passive mobilization in flexion. Rests the limb to be mobilization against the chest, and we use the other hand to stabilize the contralateral aces, and like that we will perform the variation of the hip mobilization in flexion. The next one is also a variant of the passive mobilization in flexion. The patient in the same position as before, and the therapist in the same side as the patient, and the therapist's proximal hand holds the patient's leg with the elbow supported on the patient's knee and chest, and the other hand is placed on the contralateral thigh to prevent movement. This grip is used at the end of the joint's range of motion. There is also another variation of passive mobilization in flexion. We tell the patient to put in side lying position laterally, and the therapist stands facing the patient. Using a cup grip, the therapist supports the patient's thorax on the anterior part of the leg and knee, or rests the knee on the therapist's abdomen, and the other hand provides stabilization in the lumbar region. The movement is achieved through the therapist's own body. And the last variation of passive mobilization in flexion, therapist position behind the patient in side lying position. The therapist applies a technique involving 3 contact points: thoracic support on the patient's pelvis, supporting the healthy hip in extension by placing the other hand on the thigh, and hip flexion is achieved through manual contact applied to the knee, encompassing the lower part of the thigh. We can perform a resisted mobilization in flexion, a patient in supine position, and the therapist stands laterally, and we will apply a resisted in the thigh while the patient do the flexion. Another mobilization of the hip is a passive mobilization in extension. We tell the patient to put it in prone position, and the therapist uses a cup grip on the anterior aspect of the thigh. The other hand stabilizes at the pelvic level and sacrum, and like that we will perform the mobilization. In this kind of techniques we have some disadvantages. For example, the patient can't see what we are doing to them. There is also a variant of the extension mobilization from the pelvis. The patient position is supine with the contralateral limb flexed and the limb to be mobilized extended, and the therapist positioned laterally rests on the contralateral knee using an axillary grip, placing their hands on both sides of the pelvis and performing a maximum hip flexion and extension tilt of the contralateral pelvis, and like that we will perform the mobilization. Another variant is a passive mobilization in extension, supine mobilization at the edge of the treatment table. The patient is in the prone position with their abdomen supported on the treatment table. The healthy hip is flexed and the affected limb is suspended, and the therapist stands laterally and behind the patient's thigh, preventing any movement, and using one hand placing on the anterior aspect of the thigh, the therapist kicks the hip into extension, and like that we'll perform the mobilization. The next mobilization is a contralateral mobilization with the therapist positioned behind. The patient is in lateral decubitus position, and the therapist uses a 3-point grip. The pelvis is stabilized with the patient's torso, and the distal hand uses a cup grip under the knee of the leg to be extended. The other hand stabilizes the opposite knee, and the extension is performed with the upper leg, and like that we'll perform the mobilization. The last variation of the extension, we tell the patient to put in prone or ventral position, and the therapist is in the distal position, supporting the end of the patient's thigh on their shoulder with crossed hands. The therapist applies a grip on the gluteal area taking advantage of the crossing forces, performing an hip extension in supine mobilization. We can also perform a resistance at this position, patient in the same position, and the therapist stands laterally applying a force on the posterior part of the thigh. The next mobilization is a passive mobilization in abduction. At the edge of the treatment table, the patient in supine position with the contralateral limb stabilized against the table, and the therapist position themselves on the same side as the limb to be mobilization using a bimanual supracondylar grip, and the therapist simultaneously applies the traction to the limb and performs like that the abduction of the hip. We have also a variation of the abduction called a pelvic descent mobilization. The patient is supine position and the therapist on the same side as the limb to be mobilized, and the thigh is held by a cup grip with the forearm resting on the medial aspect of the knee, and the other hand is used to stabilize the pelvis at the anterior superior iliac spine, and the abduction movement is performed like that. The next mobilization we are going to perform is an abduction in lateral decubitus. The patient in, as I said, lateral decubitus, and the therapist positioned in front of the patient. The therapist lifts the limb to be mobilization and places their thorax against the anterior aspect of the thigh and uses the other hand to hold the lateral aspect of the thigh, and like that we will perform the abduction. We can also do a resistance of the abduction of the hip, telling the patient to push to our direction, and we will perform a resistance on the lateral aspect of the thigh. Now we're going to perform an abduction in flexion. The patient is positioned in superior or dorsal decubitus, and the therapist on the contralateral side to the limb be mobilized, and the therapist holds the limb to be mobilized with a cup grip on the posterior side of the knee. With the other hand and forearm, the therapist supports the ilium and prevents the pelvis from descending. So let's continue with an abduction by removing the contralateral limb, the patient in a side-lying position with the opposite limb flexed and the resting on the cushion or wedge, and the therapist stands behind the patient using a cup grip to perform abduction. With the other hand, the therapist stabilizes the pelvis on the contralateral side, preventing lateral tilting, and like that we will perform the mobilization in abduction of the hip. So now we're going to perform an abduction in contralateral side lying position. The patient in position in the contralateral side with the knee on the side of the lying position, stabilized in flexion, and the therapist stands behind the patient and supports the lower limb using a cup grip on the medial aspect of the knee, and with the other hand the therapist applies a fixation with the elbow extended, and like that we'll perform the mobilization. The next mobilization we're going to perform is a rotation in knee flexion. The patient is seated on the treatment table and the therapist position themselves distally, and we're going to perform an internal rotation. The therapist stands between the legs of the patient, and like that it performs an internal rotation. And now we're going to perform a rotation knee flexion, but an external rotation is achieved by elevating the therapist's arm, so the therapist stands outer of the legs of the patient, and with both hands it performs the rotation. Now we're going to perform a variant of rotation, but in prone position, the patient, and the therapist is positioned laterally, and the therapist grasps the ankle with the palm of the hand and uses the tibial lever to perform the rotation. The other hand is placed on the pelvis to prevent from lifting. Now we're going to perform a rotation in supine position with the knee and the hip flexed. The patient in supine, as I said, and the therapist position themselves on the sides of immobilization. The therapist cups the leg using the arm and chest to support, and the other hand is placed on the pelvis to prevent compensation. And like that, we will perform the mobilization. We continue with an external traction with hip flexed. The therapist stands laterally to the patient, and the patient is positioned in supine, lying with the knee and hip flexing at 90 degrees, and using both hands the therapist perform a traction grip, crossing their fingers over the proximal inner thigh. And like that we will perform the mobilization. The next one is a caudal traction with hip flexed. The patient is lying on their back, and the therapist is placed on the patient's flexed knee over their shoulder. Using both hands, the therapist performs a traction grip by crossing the fingers over the proximal inner aspect of the thigh, and the traction is applied caudally. And like that, we'll perform the mobilization. So we continue with a caudal traction with hip extended. The patient is lying on their back, and the therapist stands laterally and leans forward, and the distal hand cups the tibial segment, and the proximal hand joins the distal hand on the inner side of the knee, and traction is achieved through the therapist's distal inclination.